Well, everybody, welcome back. It is 3:15 here, and we are going to move on to the final section of the long-term services and supports presentations for the day. I'd like to introduce the team from the University of Texas, San Antonio, health division there. Part of them affiliated with the Biggs Institute on Alzheimer's and Neurodegenerative Disease. We have three presenters this afternoon, excuse me. Dr. Angelica Davila, Juliandra Bryan, and Angela Torres, because they have a multidisciplinary approach to community-based care, but also in-home care. So I'd like to, Angela, I believe Dr. Davila is going to start us off. Very good. Welcome.
Thank you. And I think Ms. Bryan is trying to get on. Have we let her into the conference?
Okay. And we've combined your slide decks. So we have a singular slide deck. And Helen, if you'd like to go ahead and start the slide.
Thank you. And we're very grateful for the invitation. So I'm Dr. Angelica Davila. We have Ms. Juliandra Bryan, one of our nurse care managers, and Angela Torres, one of our social workers with UT Health. And we are all also part of the Biggs Institute for Alzheimer's and Neurodegenerative Diseases. And we will be talking about Cariños model, our interdisciplinary model of outreach, care, and support in Southwest Texas. Next slide. Again, just more information about us. Next slide. And no financial disclosures. Next slide. Again, my section will be talking about the clinic and our home visit program as a whole. And then Ms. Bryan will go into our guide model and the development of that. And then Angela Torres will talk about our interdisciplinary teams. Next slide. So my objectives will be discussing and defining the Cariños model, how we've developed it, lessons learned, and future needs for the populations we serve. Next slide. So Cariños will go into the acronym and what it stands for. So compassionate, coordinated, and comprehensive care across the clinical settings that meets for older adults' needs beyond the office walls. Really advocating for patients and families with other clinicians and healthcare partners, respect for what matters most to our older adults, intentional redesign of processes and activities to meet older adults' needs, nurtured relationships with families, social service agencies, and community partners. Older adults are wise and they know what they want, and we need to listen to what they say. So really, again, just focusing on we are there to help them in their journey. And supportive care for better quality of life. And cariño is a Spanish term for fondness, affection. Next slide. So this is a schematic of how our whole practice is organized. And so obviously it's a little much and we'll go into detail. But to start off is going to be the ambulatory clinic and its team and our patient, which is at the center, which is the heart of our model. Next slide. So our journey always starts, next slide, with our team members. And so these are a few of our team members at our holiday party this year. But the heart of our model really comes back to engaging and building the clinical team that are then providing care to our patients. So this picture shows our interim practice manager, our front desk, our nurses, our community health workers, our pharmacists, our MDs and our nurse practitioners, our call center agents as well. They're actually offsite, but again, building our team as one unit is part of the Cariños model in providing the best care we can. Next slide. And again, like I said, I'm going to focus primarily first on how we are building our team to provide the best care. Next slide. So again, the first component is ensuring that our team members know why we do what we do. Why did they choose to be part of a geriatric practice, right? Why do they come to work every day? So we worked on building a common mission and a common vision so that when things get rough, right, we reflect on what is our purpose here and how do we continue to put our patients' care as the primary despite anything that's going on. And when we talked about intentional, efforts, process improvement is a part of that. We know we have multiple things, as you saw in the schematic. It's not just clinic, it's home visits, it's hospital, it's nursing homes. There's so much room for change and different parts of the journey that we really need to look at each process and try to improve things so that things are running as smoothly and as efficiently as possible. And with that, we do have to take time for reflection and course adjustment, right? How are things going? Making sure, so we actually have an 8 o'clock daily huddle where all our team is together, our clinicians, our call center, our nurses, everybody's there. And at the end of every huddle, we open it up to say, hey, what's going well, what's not going well? Does anybody have anything that they want to bring up? Because we want to be able to reflect and think about the things that are not going well so that we can improve them not only for our team, but also for our patients. So that also comes to the safe work environment. Our team are important stakeholders in our clinic, right? They need to feel confident that they can share things that are not going well so that we can create a better environment for them. So we want to encourage them. We really focus daily on making sure our team feels valued and engaged. Along with that is accountability also. Like I said, we have multiple layers of things that are going on every day. And as we task things to our staff members and our team, we want them to also know that we need to hold them accountable. Not necessarily to get people in trouble, right? We hold accountability as, hey, if our right faxes, are not being able to be clear today, who are you reaching out to? You're the person that says, hey, I need help, right? Who can help me? Who has, been able to accomplish the other duties they were tasked with? Who can help me so that we can get this stuff done for our patients? So again, accountability, safe work environment, not to chastise people, but so that we can come together to provide the care that we need to for our patients. Electronic health record optimization. So UT really works very hard. We're Epic users, and they are constantly upgrading, and we're constantly trying to learn how to use our electronic health record the best possible to be more efficient for us, because time is just so important for all of us. And then we get into building our medical home neighborhood. Next slide. So our Cariños model, and again, this may be a little hard to see for some, so I'm going to just briefly go over it, and then there's another slide that shows a little bit more clearly. But our Cariños model is a comprehensive model. So our clinic is our hub, like we said, is the center. But if you go up to the top, right, we have an inpatient program. So we go to a hospital that we provide geriatric and palliative care consults at our hospital. If our patients go to the hospital, we are notified when they are there. We still stay as consultants, but we are checking in on our patients and checking in with our families. Then you'll see in the green, the rehab and long-term care facilities. So we do go to an inpatient rehab, and we also go to 3 nursing home rehab facilities, and we check in. We're the primary there to check in on our patients and their families. In the blue, you'll see the home health and hospice agencies. We have a couple of home health agencies, and we have about 4 hospice agencies that we work with directly. We are the medical directors. So again, if we send our patients and if our patients choose to go to these companies, we're able to connect with the nurses, for home health. If something's going on, I get a message in the clinic that a patient is not doing well. I know they're on a certain home health. I can text the DON, say, hey, I need someone to go check in on them. They can relate back to me, and we can figure out what's going on for the patient. And same with our hospice agencies. We're the medical directors. Our nurses are contacting us all the time to provide the care that we need to for our hospice patients. And then we started building some of our outside agencies, right? Building relationships with Alzheimer's Association, Agency for Aging. A lot of what we do is knowing the resources to provide the best information for our families. So we need to keep learning. We need to keep learning about what's going on outside in our community to provide that information. Senior centers, DME, transport agencies. Again, all that information is changing regularly. Our benefits coordinator, is always calling companies to kind of gauge who's providing the best care, who's providing the fastest, right? Because that's another issue for our DMEs. But again, just really learning about resources and continuing to be on top of that to provide the best care. And then obviously our specialists, and these are specialists inside of UT and outside of UT, right? If our patients are having an issue, us reaching out to a specialist, providing our cell phone number, saying, hey, let's work together so that we can continue to do the best possible. The whole goal of everything is obviously to take care of the patient the best possible, but also to minimize hospitalizations, right? Hospitals are not the best places for our older adults. So we're trying to minimize hospitalizations by being coordinated in their care. Next slide. And again, this just gave a little bit of a clear representation of the previous schematic. Next slide. So this picture actually can have 2 meanings for me. And one of them focuses on the actual patient care that the patient sees, right? The patient sees that they come to our clinic, we provide medical care, and they leave. But the reality is that there's a whole groundwork under what we do to really build the type of clinic and practice that we have. And again, like I said, continuing to learn and find resources, because those are the things that families need. And if we don't know it, right, they're not going to be able to get that information. So really just what we do may look like a small portion, but obviously there's a whole lot of work under it. And then this is also a double meaning for us as well, because we also recognize that we provide care to about 3,000 patients. But if you really look at the greater San Antonio area, and if you even look at South Texas, that's a small tip of the iceberg, right? And so it's one of those that we feel like we are being impactful, but how impactful are we really being, right? Because we know that there's still a whole large population that we are not able to get to. Next slide. And so we always think about our barriers to care. And one of the biggest that stood out to us was going to be lack of transportation and ability to come to visits. So in our greater San Antonio area, obviously there's different locations, and our clinic is currently located on a little bit more affluent north side of San Antonio. And I found that I had a few patients taking multiple buses to get to the clinic to come see me, because they lived in the more underserved areas in the south or west side, and they did not have good transportation. And I have older adults taking, multiple buses to come see me. So we really started kind of brainstorming at that point how could we venture out to be able to touch more patients who really need us, right? Who probably have higher increase of poverty, more language or cultural barriers, right? Have more issues with inability to navigate the healthcare system. What could we do to reach out to them? Next slide. And that's when we really started forming our Cariños en su casa, or care in the home, focusing on serving our vulnerable population, obviously largely Hispanic in San Antonio and in South Texas. Next slide. And so Cariños en su casa, just like our clinic, is really a comprehensive, coordinated, compassionate care. And we have incorporated our promotoras, or trained community health workers, to assist us in all the other barriers that we have found when we're taking care of persons in lower economic areas or underserved areas. One thing that does make us a little different from other home visit programs in San Antonio is that we are still physician-led, right? With UT, we are physician-led primary care. So we as the physicians are going out and doing the home visits as well. And we work in dyads with our nurse practitioners, so we alternate visits. But that's how our care is coordinated. Next slide. And so in general, who we serve has had to change a little bit over the years. We are 5 physicians, 5 geriatricians, and 5 nurse practitioners. And about 5 years ago, at least when I came in about 7 years ago, the criteria was a blanket 65 and older. 65 and older is a lot of people in San Antonio. And so we were drowning in the amount of patients that wanted to come see us, and our ability to follow up on the patients that we already had. So about 4 years ago, we really did start putting criteria in that they had to be 85 and older, right? Frail, older adults. And then we started kind of introducing, or patients with dementia. That's when we started integrating a little bit more with the bigs. And we started putting in a criteria of a patient with dementia of any age could definitely come see us, and we would then again provide support. In the last 2 years, we are really honing in on persons living with dementia and their families, still accepting the very frail 85 and older, but really now kind of niching out and focusing on persons with dementia. And you'll notice at the bottom of this too, it says patient caregivers. As we've done home visits, if a patient is homebound, family member can't get out to get their care, well, then we're going to provide the care for them as well, because we need to take care of them, obviously, as they are taking care of their loved one. So we have incorporated, caregivers if they are homebound, and it really is just the right thing to do for them. Next slide. So our lessons learned, and again, our most of our lessons learned are more into the integration of home visits and how to make it work. And there's a lot of logistics, a lot of operations. We have a academic center that is very strong in providing, clinical medicine in the hospitals and in clinics, but not necessarily do they have it figured out in terms of home visits. So we had to work a lot with clinical operations, working a lot with the electronic medical record, and it's still, there's still a lot of barriers to making this as efficient as we would hope for. So scheduling is probably one of our biggest challenges, and being able to route our clinicians appropriately, being able to have certain designated areas that a person can go to. So all of this is really being done by one scheduling person, right? It's being done manually. And we've been searching and searching for options to to do it a little bit more efficiently, but it's got to be integrated in Epic, which has been our biggest challenge. We're also running into the financial challenges of home visits. As much as we love to do the home visits, and it's really what we feel is the best care for the patient, we see less patients when we do home visits, right? We drive ourselves, we don't have medical assistance, we're doing the vitals, we're doing the med reconciliation, we're doing everything. And that time frame of what it takes to see a patient, right, in home is much longer. And so therefore we're seeing less patients in a half day. CMS has done amazing where they have increased a little bit of revenue for clinic patients, but again, they actually went down a little bit in home visits, which just, adds to the difficulty. So we have had some financial challenges, and that's where the guide model has been another way of trying to remedy that, and that's what Juliandra will talk about next. But then also the interdisciplinary support. Another issue we were having was, again, we want to be there for our patients when they have acute issues, yet I couldn't always get a person to be able to do an acute home visit depending on where they're at, right? If somebody is in the far west side of San Antonio and a person on the far east side is having acute issues, how do I get care without making an hour drive for someone? So luckily UT Health started partnering with a urgent care at your home, which is called Dispatch Health. And they've been an amazing resource to really help continue to provide care for those acute issues that we may just not be able to do on the daily basis. And then also needs for extended team to provide support. So, again, we're dealing with a lot more issues in terms of resources, and having our community health workers, having a social worker, having other team members that can go into the home to provide support is just so necessary. Next slide. So over the next 10 years, how can we continue to expand the model? And obviously, I think it's an amazing model and worth expanding, but we need clinicians, right? We're going to need the specialists and our nurse practitioners and physician assistants to help. We also are going to need a lot more interdisciplinary team members. Again, our social workers, our community health workers. We would love to have our own physical, occupational, our own speech therapists that go to the home and provide, the education that families need. Our pharmacists to go to the home. At this point, our pharmacist is only in our clinic, but again, can do video or telephone visits to our patients in the home. And then obviously our nurse care managers going in and developing the relationships with our patients in the home. And then integration of resources that can expand outside, right, of San Antonio. So currently, I'm actually in Laredo. I provide a clinic here in Laredo for the Biggs Institute. I do geriatrics and supportive care here with one of the neurologists. But we have, some limitations there as well, right? When acute issues are happening here, how are we providing acute care for some of the patients here? And there are these new resources. The Alzheimer's Association is using a company to help with some of that. And I know that's something that we've been talking to them about. But again, as we continue to expand, how do we continue to provide the care that's necessary on a daily basis? Next slide. And that's all I have. Just talking about the Cariños model as a whole, and then Ms. Juliandra Brian will talk about our guide model and how we've worked through that. Thank you.
Hi, good afternoon. My name's I go by Julie, Juliandra, and I'm an LVN in the clinic. I've been an LVN for 32 years, and I support the team to provide care in the clinic. I coordinate care, and as of July, we started participating in the guide model of care. So that's what I'm going to talk to you today. and how it incorporates and intertwines in our Cariños model of care as well. Next slide. And that's just another slide about what we're going to talk about. The objectives today, we're going to define what the guide model is. What is guide? It's been being talked about even more so every month. We're going to describe how we're implementing the guide into our practice and some outcomes and lessons learned. Next slide. So what is GUIDE? The acronym is Guiding an Improved Dementia Experience. It's a voluntary model of care for Medicare enrolled providers and practitioners that can easily implement the program within their practice. It's comprehensive, coordinated, and supportive care provided to the patient and their caregiver by the interdisciplinary team, which consists of the doctor, the nurse practitioner, the care team navigator, nurse, and a community health worker and social worker. And also it's very intentional in its application towards the patient and the caregiver and to the team. And it's comprehensive, provided to the caregiver. So a lot of focus isn't just on the patient, it is also on the caregiver that's with the patient most of the time. Next slide. So the goals are to improve the quality of life for people living with dementia. And it also improves the quality of life for the caregiver. It provides support and resources for the caregiver, and it helps people with dementia stay in their homes longer. So as we have been experiencing applying the guide model of care to our caregivers and the patient, the family, it actually helps the patient stay in the home longer if we can provide resources and tools and education and support to the caregiver. There might be some more time before they can no longer care for the patient. Next slide. As I've already spoken on this a minute ago of what the team looks like, you know, all the team members involved. Next slide. So the first step that we took in implementing it into our practice requires identifying the eligible patients. So in our ACO and our population health department, they've helped us using our EMR, Epic, using different criteria. So guide is by zip code. They have to have traditional Medicare. They can't have any Medicare replacement plans or other insurance. And so identifying those patients, our ACO department and the IT department have come together to help us identify those. They can come as new patient referrals. As the care team navigator, I try to look at all of our new patient referrals coming in, and also scheduled patients. So one of the most fruitful ways that I've discovered over time is looking ahead at the schedule. Who's coming in next week? Identifying those patients as people with dementia or Alzheimer's, and looking at their insurance and kind of just looking at their last couple of notes to see what the plan of care is and what family members bringing them in, because of the clinicians document very thorough and identify who's with the patient. So that's really helpful. And so I spoke a little bit already about the guidelines and requirements. They also cannot be on hospice or be in long-term care. And then also the next step after you identify the patient, we want to introduce and get consent on the guide program. This can be done during a scheduled visit by the doctor, the nurse practitioner, the MA, the nurse, the care team navigator, the community health worker, or the social worker. So after I've become comfortable introducing and obtaining consent on the program, I've been coaching some of the staff in the clinic and helping them get comfortable talking about it. and then leaving a visual that CMS provided on the guide program in each room so that it's easily accessible. If the MA is in there, they can bring it up. Also, when screening a new patient, a referral by the staff while working a call or portal communication with a caregiver. So as the nurses in the clinic and the MAs, we're looking at messages on the portal, on the EMR and Epic. And so as we're having conversations, a lot of times they're with caregivers and family members for those persons with dementia. And a lot of needs are identified during these calls and messages. So constantly staying alert of patients and caregivers that we can help. And then using CMS provided information for consistency. So the message, it's important that the message and the way that it's introduced is consistent amongst everyone in the clinic. So we're trying to achieve that. Next slide. Intake and schedule. So that's the next step after we've obtained consent. We screen with the care team navigator using a template. So we created a template of consistent information that needs to be obtained during that intake call. It takes about 25 to 30 minutes if all goes well. And sometimes there needs to be a break. So I've identified during conversation and intake, I'm very aware of what's going on in the background and in the patient's home with the caregiver or by their tone or the way that the conversation's going, they might need me to call them back. Because sometimes 25 minutes with someone with advanced dementia could be a long time of attention taken away from them. Assessing their caregiver burden level. We're using the Zaret Burden Interview, the 22 question version, and we assess their caregiver burden level during the intake. Prioritize the caregiver's needs and place an urgent referral to the community health worker or the social worker. So during that intake template, it has questions to identify what their biggest stressors are at the time. And they could have a whole lot of needs, but I try to prioritize them with the caregiver to find out what their biggest burden is at that time, or it could be safety, regarding safety. That always comes first. Schedule, and then we schedule a comprehensive evaluation with the physician or the practitioner. That's in that step. It's what well, I'll tell you in a second. Okay, and then the next step is the comprehensive assessment. The clinician or the practitioner provides using a certain template tool that they've created in the EMR so that it's a consistent note and it contains the necessary cognitive assessments in developing their acuity level and their plan of care. And also establish well-known, we have found that different time frames are necessary. So if we have an established patient that's well-known to the physician or the practitioner in the clinic or the home, it can take about 60 minutes. And also we, as a care team navigator, we have to know what acuity level the patient is at the time so that we can try to provide a good amount of time for the clinician to do that assessment. And also a patient that's new to us with a mild caregiver burden, it can take 60 minutes to in the clinic and 90 minutes in the home. And a new patient with moderate to severe caregiver burden level, of course, that caregiver is going to have a lot more needs, and it could actually take up to 120 minutes. And so as we heard Dr. Davila say earlier, clinic visits, when they're doing home visits, it's a lot less time or a lot less visits when they're in the home because the patient is homebound, they have more needs, and their acuity levels are higher. So it's best if we could see them in the clinic. Next slide. So some of the outcomes we have we implemented this in our clinic in July. And we developed our team, and I went through some training to be a care team navigator. We created templates as a team, notes in our EMR with our IT department, and we met weekly. We still meet weekly, and we're constantly revamping and simplifying and trying to make the process the most efficient that we can. And so we talk about that every week. And since July, we've submitted an average of 25 to 30 every month of Medicare enrolled persons with dementia. And I believe right now we have 30 to 40. And so every month, as we're becoming more efficient and knowledgeable on the guide process, we're actually, I've seen an additional 3 to 5 every month. And we, of course, this was our first winter season. And so as open enrollment has happened, we've lost some enrolled persons with dementia to the guide program due to insurance changes. And then as the disease progresses, sometimes they end up on hospice. So we've lost some patients to hospice. And so half of our current enrolled guide patients, the caregiver has moderate to severe caregiver burden. So it's been interesting to learn, all that we have thus far in seeing the challenges of the caregiver by asking the intentional questions and not waiting for them to provide us information. We're actually seeking it out, because a lot of times I've noticed the caregiver isn't always forthright with how things are really going, and they might have a fear of being judged. And so I try to make them very comfortable during our conversations and let them know it's a judgment-free zone, that we're here to help, and it's real important that they understand that. Next slide. And so some lessons learned, I've already spoken about some of this in December and January. We're understanding, even just in the clinic without guide, the importance of checking the insurance now that January is here. And always verify the insurance prior to even introducing the program, because it could be disappointing to introduce something that's beneficial to someone and having to retract that and say, oh, I just saw that you have Blue Cross. I'm so sorry you can't do this. That can be very uncomfortable. And the importance to check in with the clinician during an appointment prior to introducing it may not be a good idea. So it's always good to check in with the clinician and say, hey, I was going to introduce the guide. What do you think? Is this a good candidate? And the visit could have been so consumed with a transition of care post-hospital visit, there's not a lot of time, or it could have been overwhelmed with another issue that it can just wait for a phone call like a few days later. And then asking the caregiver and the family if they'd like to hear about it instead of just introducing it. Say, we've had to learn different approaches. So, and then also, if possible, determine what stage the person's in prior to introducing it. So it's always important to investigate, review before, and not rush into something. So looking to see where the patient is in their disease process and kind of looking at the chart for a few minutes is always beneficial, and touching base with the clinician. So those are the things that I've learned to make it more successful. Next slide. And keeping a pristine spreadsheet for whoever's submitting to Medicare Monthly. I don't know who on this meeting right now is already participating in this, but whoever's submitting this spreadsheet, it can take quite some time to have it go through and get accepted without making a bunch of corrections. So I try to keep that pristine for our leadership that is submitting the spreadsheet to Medicare Monthly. Caregiver information is required on the spreadsheet for submission, and it's best to get that obtained during conversation and through the intake assessment phase instead of waiting till the end. And so learning how to incorporate that of what's needed to submit to Medicare makes it much more efficient. Importance of making time as a team. So that's been critical for us, as you could see in the Cariños model, how busy our clinicians are, and the importance of us taking time to go over the patients that are already on the guide program. Exposure of fragility and relationships between the caregiver and persons with dementia and their desperate need of support. That's something personal that I've added in there, that as a nurse, just seeing with, as we're doing the intake interview and communicating with them, I'm sure our home visit clinicians already experienced that, but just how fragile the relationship is with the caregiver, especially as a child, an adult child caring for their persons with dementia. This has been very impactful to me to see. I don't personally experience that, but their whole dynamics of the relationship changes, and they become almost like the parent of their adult parent. And there's a lot of different things that play into that. Some of their parents weren't always nice parents. Some of the patients weren't always nice to their children, and now they're caring for them. So there's a lot of fragility in these conversations and trying to help them. And I have found that they are desperate for help and resources. And so it's a blessing that the guide program has been implemented by Medicare, and I'm very honored to be a part of it. Next slide. And now we'll hear from our social worker, Angela, and thank you for your time.
Thank you, Julie. Hi, everyone. My name is Angela. I'm aware that we are over on our time, so I only have a few slides that I will go over with you.
Angela?
Yes.
Angela, go ahead. What we can do is we can forgo the Q&A completely if that works out best. So go ahead and get through your slides and we'll go from there.
Okay, sounds good. Thank you.
Thanks.
Next slide, please. So I'm the social worker in the clinic with the Biggs Institute for UT Health. And so the Biggs Institute is a national center of excellence for dementia and research care. And we are the one center in the state of Texas. We're 1 out of 33 in the country. And so I wanted to highlight the importance of the role of the social worker in the clinic and the supportive services that we offer. I work in the clinic alongside our neurologists, our neuropsychologists, our geriatricians, our nurses, mid-level practitioners. Earlier this morning, Christine gave a good presentation about the role of social workers with their community in Alaska, and I think she did a great job highlighting that. So this slide contains some of the similar things that they're doing there: psychosocial assessments, providing counseling and emotional support to our caregivers, advocacy, case management, helping with resources, having discussions about palliative care and end-of-life care as the disease progresses and what that looks like for our patients and for their family members. The importance of interdisciplinary team collaboration. So our team today, Dr. Davila, Julie, and myself work together closely to provide interdisciplinary team support to our patients and family members. And we really try to help each other connect the dots when healthcare can be quite fragmented. So also advocacy for systemic change. That's something that has been heard quite a bit today in all of the presentations. So next slide, please. So a few things that we're doing over at the Biggs Institute, along with me working in the clinic and seeing patients in the clinic when they're receiving a diagnosis of dementia, or they're coming in for follow-up care with their cognitive behavioral neurologist or their neuropsychologist. I meet them in the clinic or speak to them on the phone or on Zoom. I also help facilitate support groups, and we've tried to create some support groups that work alongside with our Alzheimer's Association. So in San Antonio, we have a great Alzheimer's Association that has support groups that are already in existence. So the groups we've created are something different that do not already exist. The first one Julie mentioned adult children who are caring for parents. So caring for a parent with dementia is a very unique experience for adult children who might be in the sandwich generation of raising kids or teenagers while also caring for their parent. So this one's a virtual group that we've had for the last 5 years. It's pretty well attended, not only exclusive to people in San Antonio, we've opened it up to anybody in the nation that's interested, as long as they're caring for a parent with dementia. We have a grief and loss support group that I facilitate with our licensed professional counselor. We specifically discuss the topic of ambiguous loss, the grief and loss aspects of anticipatory grief, as we think of how difficult the transitions are as we are caring for somebody with dementia. Grief isn't always spoken about. And so in that group, we have people who are actively in the caregiving stages, maybe in the later caregiving stages, and really struggling with that anticipatory grief, and even people who have been caregivers for quite some time who have lost a loved one to dementia. And then lastly, we do a dyad support group for persons with a Lewy body diagnosis and their care partners. So we meet all together as a group, and then we separate the individual diagnosed with Lewy body dementia and then their care partners. This next slide goes over some of the counseling and social engagement opportunities. Like I mentioned, we do have a licensed professional counselor who schedules counseling sessions with some of our patients, and especially caregivers or care partners who need assistance walking through the emotional aspects of a disease. We also do some community engagement with our local San Antonio Museum of Art that engages patients and their care partners in different art activities. In the past, we've had yoga events and different things like that to keep our patients and their family members engaged. Next slide, please. So a couple of key insights, lessons learned, opportunities for improvement. I've been the social worker for the last 4.5 years at the Biggs Institute. And one of the biggest insight is the support services that are offered by social workers. I'm the one social worker there, but we do have a couple of community health workers in our geriatrics department that work really closely with our patients and family members. We play a crucial role in the healthcare setting and trying to help patients navigate the healthcare system. The other key insight is caregiver support. So emotional, logistical, financial, that's really essential. And then we've talked about several times the collaboration across the disciplines to help minimize the gaps in care and to enhance the patient outcomes is incredibly important. So lessons learned, as many of you know, services offered by social workers and community health workers, it's not reimbursed by Medicare, Medicaid, or private insurance. So for example, I'm paid a salary through the Biggs Institute, and I'm not a reimbursable provider at this time. And so that's something that it would be great for us to have more social workers, more community health workers to help all of our patients, but funding is an issue there. Another lesson is in-home care and respite care is typically a private pay expense. It's not covered by most insurances. The exception there is if you have a long-term care insurance policy. And another lesson is support groups and social engagement events also require funding, which is limited unless we've applied for specific grants that have limitations as well. So opportunities for improvement, we'd like to continue to advance the family support system for the caregivers, improve access to community resources. And as I mentioned previously, my goal would be to expand the social work, community health worker program and counseling program so that we can serve more patients and families in our clinic. Next slide. So this is my last slide. Just as we think about the foreseeable future, even 10 years down the line, how do we continue to address the ongoing needs of the population we serve? So I broke it down with persons living with the disease and then their care partners. As many of you mentioned before, the importance of person-centered care that's the core of what we do as social workers. We start where the patient is, start where your client is. And so always remembering that every person is different. Every case of dementia is different. Every family member has different needs that we need to be cognizant of. The interdisciplinary collaboration, I can't speak, I speak about that often. That's really important. And of course, the federal funding to assist with personal care needs. With our care partners and family members, access and funding to respite care, whether that's in-home or facility respite care, continued training and education, mental health and emotional support, and lastly, funding for in-home care. And I think that's my last slide. See, nope, it's not one more. Okay. So yes, this is my last slide. So how do we expand our model, policy and advocacy? I was really honored to be offered the opportunity to speak at this forum today because there's so many important people that have the same mission that we all do. We really want to see how do we enhance the services for our older adult population, get more recognition and funding, resources, things like that for our patients and their family members. So we've talked about the funding and resources, legislation, and then guide model. Julie did a great job of talking about the guide model. Since we've just started that in July of last year, really be interested for us to utilize that the data that we receive from that, and so that it is able to substantiate the need for increased funding for the aging population and persons diagnosed with dementia. Of course, with family and caregiver involvement, education and continued training for family members. I feel like that's a lot of what I do. I provide a lot of psychoeducation about the disease, about insurance, about all kinds of things. Offering family-centered care, always making sure we're involving our families in the care planning and decision-making throughout this whole process. And then recognizing our caregivers. So advocating for policies that recognize and support family caregivers and include financial assistance, respite care, and access to professional services. So that's the end of my presentation. Thank you all for the opportunity.
I want to thank Angela, obviously you for coordinating at that end and ending up the talk today. Dr. Davila and Juliandra, thank you so much. I have a personal connection to UTSA because I was there as a speaker back in March. And I specifically wanted this Cariñas model presented today because it speaks to not only culture, it speaks to community, it speaks to partnerships, and it respects the individual within their home environment. And I think that that's something I remember the days, at least maybe our parents did, when doctors made home visits. And that went away for a number of decades, except in very odd and rare conditions. But they've been working on this model for, as I believe, the coordinating physician, Dr. Patel, this has been an evolving process for them for 20 years. And now they're getting it to a place that they understand the needs of their community, and yet it will continue to evolve. But we, as a governmental, representative, so to speak, we need to be looking at what we can do to support more of these as our population ages and the incidence of dementia increases. So I want to thank all of the speakers on behalf of the LTSS subcommittee. And we're going to go on now to public comments, and I hope you'll kind of stay on and listen. Thank you.
Thanks to all of our presenters today. I was just reflecting on the fact that most of these programs are relatively young, right? Compared to NAPA, we've been doing this for 10 or 12 years, and a lot of these programs are getting to maturity at 5 years, even less than that in some cases. And so it really is important that we keep our foot to the pedal and keep this work going, because we're just starting to see the results of the federal efforts get to the local level and get to the communities of need. So with that, I'll turn to our public commenters. All three of them, I'm sorry, we have one person in person and then we have two online. So our first presenter is a virtual presenter, Megan Dickens, and then we're going to turn to Margot Rondeau, who I believe is in the room. So Margot, you'll be up here. I'll bring you a microphone, and Megan, if you're available, the floor is yours.
Hi, thank you so much. Hello, everyone. My name is Megan Dicken, and I am the Public Health and Aging Associate at the International Association for Indigenous Aging, also known as IA². Our mission is to enhance the health and well-being of older adults in Native American communities and improve the quality of life for Indigenous elders. As a Native American woman myself and an enrolled member of the United Homa Nation of Louisiana, I am grateful to bring an Indigenous perspective to our work at IA². IA² manages the American Indian and Alaska Native Resource Center for Brain Health as part of the Center for Disease Control and Prevention's, the CDC's, Healthy Brain Initiative. We are excited to share with you our important role in creating the second edition of the newly released document entitled The Healthy Brain Initiative Roadmap for American Indian and Alaska Native Peoples, in collaboration with the Alzheimer's Association. As you learned in the earlier presentation, the roadmap is a guide that helps Native communities improve brain health and effectively address Alzheimer's disease and related dementias. Native Americans experience dementia and other chronic conditions at a much higher rate than the national average. Due to the uniqueness of our population and distinct challenges we face, the new roadmap was designed to make sure it respects Native traditions and knowledge while providing actionable steps to address brain health and dementia care. We at IA² played a key role in accomplishing this by adding culturally meaningful stories and images that honor the traditions and knowledge of American Indian and Alaska Native peoples. We also convened a number of listening sessions with representatives of Indigenous communities to help guide the early development of the roadmap. Our expertise helps ensure that the roadmap reflects the needs and perspectives of Indigenous elders and their communities. This updated roadmap, led by the Alzheimer's Association and the CDC, builds on the success of the 2019 edition. More than 200 American Indian and Alaska Native community members and public health professionals contributed to help update it. Members of IA² staff, our Brain Health Executive Committee, and our HBI Advisory Committee were all engaged in this effort. The first edition of the roadmap was successful in increasing awareness of Alzheimer's disease and related dementias and creating tribal health efforts to address dementia. The goals of this second edition are to provide clear, culturally appropriate steps to further enhance brain health, improve dementia care, and better support caregivers in Native communities. This edition aims to deepen the impact of the first roadmap by integrating more community input and the latest health innovations tailored to the needs of Indigenous elders. We encourage you to check out the new roadmap on our website, www.ia²org, under the Initiatives tab, then under the Roadmap for Indian Country tab. It can also be found on the Alzheimer's Association and CDC websites. Thank you for your attention and interest in improving the lives of Indigenous elders.
Thank you, Megan. Margot, the floor is yours. And then if Linda Jacobs is online, I don't see her, but Linda, if you're there, you'll be our final comment.
Oh, there you go. Okay. Good afternoon, and thank you so much for the opportunity to speak today. My name is Margot Rondeau, and I'm the Senior Director of Health and Wellness at the National Down Syndrome Society. Over the past several years, we've worked to ensure that someone from the Down syndrome community addresses this council to share how Alzheimer's disease profoundly impacts our community. Researchers, physicians, family members, and self-advocates have spoken here on a variety of topics related to Down syndrome-associated Alzheimer's disease, DSAD. We are deeply grateful that this council has listened and responded by increasing the inclusion of Down syndrome in your work. However, the reality remains that without intentional inclusion across each of NAPA's council's 6 goals, our community will continue to face the challenges of exclusion and inequity. Everyone here agrees. Alzheimer's disease is devastating for individuals receiving the diagnosis, as well as for families and caregivers. In my current position, I spend a good amount of time supporting families who navigate the daily challenges of DSAD. These families manage the heartbreaking symptoms of the disease while mourning the gradual loss of the person they once knew. As the mother of a 7-year-old with Down syndrome, this isn't just professional for me, it's personal. I live every day knowing this will be my reality. This is my baby girl. For the past 7 years, I've dedicated my life to ensuring that she has the access to therapies, opportunities, and resources to thrive and reach her fullest potential. Yet I do this with the knowledge that one day she's going to lose it all. Every skill we've worked so hard to achieve will be diminished through the devastating onset of Alzheimer's disease. And this isn't just my nightmare. It is the shared nightmare of every parent in the Down syndrome community. Individuals with Down syndrome face a staggering 90% lifetime risk of developing Alzheimer's disease. And I mean, think about that 90%. It is a reality we cannot ignore. Today, we stand at a pivotal moment in history. Scientific advancements have brought us closer than ever to the possibility of preventing Alzheimer's disease. I believe in the brilliance and dedication of researchers working towards a cause. But how devastating would it be if these breakthroughs became available to the general public, yet excluded my daughter and the 200,000 people living with Down syndrome in the United States? I'm here today to ask you, as leaders and decision makers, to ensure that this doesn't happen. As treatments and cures are developed, we must guarantee that they are accessible to everyone, including those with Down syndrome. My specific ask is that the newly created seat on the NAPA Council for a community disproportionately affected for Alzheimer's disease be designated for the Down syndrome community, because their lives are just as valuable. Their futures matter just as much, and they do not deserve to die from Alzheimer's disease. Together, we have the power to create a world where no one is left behind. Please help us ensure that the promise of a cure for Alzheimer's disease is a promise kept for all. Thank you.
Thank you, Margot. And then is Lynn Jacobs online? Okay. We have two public commenters who are unable to join us today to provide their comments, so we will disseminate those to the group afterwards. And thank you, Margot, and everyone who was able to join us today for the comments.
Okay, thank you. What an exciting day we have had. I'm going to now go through our concluding remarks. And I took notes throughout the day, and I wanted to highlight a few things that you probably already have in your notes, but I want to specifically lift up from the federal updates. Number one, Arlene Bierman said, "I need your help." There is an RFI out there where we want to find out how ageism is impacting dementia. We all have an opinion on it. Please submit your comments. That's by March 15th. I was impressed with the presentation on the roadmap for American Indian and Alaskan Native peoples. The presentation was great, but the video really told the story. It was succinct, but it told everything, including how bringing in the culturally relevant perspectives through the IA² was used in that. So I wanted to specifically lift that up. Moving further, the summary of the evidence of risk prevention, including recommendations for further research, was pointed, especially in the faith-based communities and workplace. We've talked a lot about research. We've talked a lot about clinical practice, but those areas of the faith-based community and workplace, we've not really had in this community before. And lifting that up and understanding how there's a need to collaborate with them is important. Many states are starting to embark on their state multi-sector plan on aging. And they're bringing transportation to the table. They're bringing healthcare to the table. These are two other seats that need to be there, faith-based and workplace. Thank you for giving voice to LGBTQIA, not just the veterans, but all. And the comment about, do I have to go back in the closet to receive long-term care, should make all of us think about that. As dementia progresses and you have to rely on other than yourself, do you have to really have people question who you are? And the presentation about the true intersectionality of those experiencing questions about who I am and the validity of that. And then when you have dementia and their caregivers, those are real challenges that they're experiencing, accessing care, social services, and economic support. I also heard very loud and clear the need to replicate PACE and adult day communities for LGBTQIA+ in multiple communities. And we have a vehicle because PACE is in more than 31 states. That's at least one area that it can be disseminated. The afternoon and the rest of the morning focused on long-term services and support. And I appreciate how that has spanned diverse communities. We usually look at long-term services and supports as the services. But as we got a cultural view of those, we realize that how important it needs to be different in every community, especially understanding that you can't really get much from the community until you're in the community, being present and gaining that relationship before you offer your service or ask. I'll pose this question: how do we fund it? Is it the type of things that can be expanded through Older Americans Act? Is it the type of things that can be funded through evidence-based initiatives? I'm not sure, but it's something to think about. I enjoyed the Karena's model because I did a lot of home care. My most rewarding experience was doing home care for patients living with dementia. In my last 2 years of clinical practice, I found that it is important to do, but there are some aspects of it that could be modified. I actually went each time with my medical assistant, and that sped up the visit. But it also allowed me, once I was in the home for that first time and did my comprehensive assessment, not every follow-up needed to be done by me in the physical environment, but at least it could be done through telehealth. And it's worth exploring that, visually seeing them, because you've built that relationship, you've seen that environment, and sometimes having the paramedic do some of the assessments for you can actually expand that service. We do need to find more reimbursement for the social worker, community health worker, and community enrichment programs for those living with dementia. I'm not sure if the new CMS codes for personal illness navigation will really fit that, but it's something to consider and explore. But as we hear from the guide models, the things that they're learning is beyond respite. It's many services through the social worker that are not reimbursed, but that will make a difference in people being able to stay in the community longer. So I will end there and thank again our representative from the Down syndrome of how we need to also include all populations across all 6 goals. So I thank everybody for attending today on phone, online, in person, and it was a very rich time today. We'll be back together in April, minus me. I'll actually be in Japan, but but that will be on research, and my colleague, Dr. Randy Bateman, who I believe is on the phone, will be actually chairing that particular one. And we'll have a 1-hour risk reduction session too. Any other closing remarks or comments from our members on the council in the room first, and then I'll go on the phone. Seeing none in the room, any closing comments or remarks from my council members who are on the phone? Randy, you said no. Okay, thank you very much. Okay. All right, goodbye.
Produced by the U.S. Department of Health and Human Services.